This video will cover management specific to COVID-19. Much of this material has been covered in other videos. However, given the importance of COVID-19, we wanted to provide one video that is a comprehensive resource to collate the information that we have at this date. Patients with COVID-19 are presenting with hypoxemia as the major issue. In this example, the patient had an SpO2 of 92% on room air. While that's mild hypoxemia, with any movement at all, the patient decided profoundly down to the 80s. Other clinicians are reporting that they're seeing patients present with SpO2s in the 70s, 80s, and even lower on room air. The patients are usually oxygen responsive, but not to the degree that we would like to see.
Here's an example of X-rays for a patient with COVID-19. Radiographic evidence of COVID-19 pulmonary manifestations can be highly variable. Although the majority of patients admitted with symptoms will have abnormalities on a chest X-ray, approximately 1 in 3 patients will have no abnormalities at the time of admission. Chest X-ray abnormalities may be most prominent about 10 to 12 days after the disease process starts.
The first X-ray was his X-ray when he presented to the emergency department. You can see that he has bilateral, patchy infiltrates, and he did have an oxygen requirement at that time, approximately 2 liters nasal cannula. The patient was admitted to the regular medical floor in reasonable condition. However, unfortunately, over the next 12 hours, he had a significant decline in his respiratory status, and he was admitted to the intensive care unit. The subsequent chest X-ray about 36 hours after the initial presentation, showing significant progression of the bilateral patchy infiltrates. This X-ray was taken right before he was intubated.
Management of hypoxemia is key to patient survival in COVID-19. Choices of supplementation vary due to varying infection control policies and the types of oxygen devices available. In general, the evidence shows that high-flow nasal cannula is an excellent means of supporting patients with hypoxemic respiratory failure. It works very well and is associated with improved outcomes. But in patients with COVID-19, there has been concern that if we use high flow, this could result in more infections in healthcare workers and other people due to increased aerosolization of the virus. Anytime a patient with respiratory illness like COVID coughs or sneezes into the room, the risk of infection to others is increased. It is not clear the extent which adding high-flow nasal cannula makes this worse. Many institutions with access to high-flow nasal cannula and PPE are using high-flow nasal cannula regularly in the care of COVID-19 patients. And some studies have shown that the risks of aerosolization with high-flow nasal cannula are not as severe as previously thought. While the data are still being evaluated, when using high-flow nasal cannula, in addition to providers wearing appropriate PPE, a surgical face mask should be placed over the patient's mouth and nose to mitigate the risk to others in the room. Non-invasive positive pressure ventilation, known to many as CPAP and BiPAP, are controversial. Similar to high-flow nasal cannula, there are concerns that non-invasive positive pressure may increase the risk of aerosolization and risk to healthcare workers. However, there are few data to guide this at this time. The issues of aerosolization aside, an additional controversy with positive pressure ventilation is that it is questionable if this should be used in ARDS patients. However, non-invasive positive pressure ventilation may be associated with worse outcomes in some patients, possibly due to delaying intubation and mechanical ventilation, or by causing barotrauma and volutrauma, as patients are able to take large tidal volumes with their spontaneous efforts. This can lead to self-induced lung injury. With all this in mind, the potential benefits and risks of using non-invasive positive pressure ventilation in COVID-19 patients are unclear. The existing guidelines and practice patterns on the use of non-invasive positive pressure ventilation are quite variable. The take-home message for COVID-19 appears to be consistent with the current opinion about the use of non-invasive in ARDS. Its role in most settings is probably limited, and it's likely to be most successful when used to treat mild to moderate ARDS, or scenarios where there's significant hypercapnia or superimposed COPD, obstructive sleep apnea, or heart failure, where non-invasive positive pressure ventilation could be indicated.
When we determine that the patient needs to be intubated, we provide sedation, we provide neuromuscular blockade, we lie the patients flat, and they de-recruit. So the heavy, boggy lungs will collapse upon themselves, causing de-recruitment and causing profound hypoxemia. All of this is further exacerbated by the fact that we have challenges in pre-oxygenating these patients as we would other patients. We know that flush flow oxygen is an excellent way to pre-oxygenate patients who need to be intubated. However, the concerns about aerosolization remain. Similarly, bagging the patients or using non-invasive ventilation have the same concerns.
Recent data support that intubation can be done safely in these patients with appropriate use of protective personal equipment, using the most experienced clinicians for intubations, with a modified rapid sequence induction, and using video laryngoscope when available. Many institutions are avoiding manual bag valve ventilation after intubation and placing the patient directly onto the ventilator to reduce aerosolization risk. If a bag valve resuscitator is used during an emergency or for safety, a filter must be utilized to protect the clinicians in the room. Once you intubate your patients and place them on the ventilator, a bacterial or viral filter is absolutely mandatory to maximize the protection of everyone. The filter needs to be placed between the patient and the bag or the ventilator. I would note in this picture we have here, it would be a little more optimal to have the filter below the end-tidal CO2 detector instead of how it is portrayed in this illustration. Having the filter next to the endotracheal tube would minimize the number of disruptions that are needed to open the system. Early in the COVID-19 response, some centers have pursued the approach of intubating earlier than would be usual practice with other patients with hypoxemic respiratory failure and ARDS. There were multiple proposed reasons for this, including concern and anticipation for rapid deterioration, as well as avoiding potential self-induced lung injury. Robust data supporting improved outcomes with this approach are not available. In contrast, some centers have advocated avoiding intubation perhaps to a greater extent than would be otherwise used in ARDS patients. This has been done due to concerns for exceptionally high mortality rates with some intubated ARDS patients with COVID-19. However, more centers now are reporting mortality rates of intubated COVID-19 patients that are comparable to other patients with similar ARDS. At this time, management of COVID-19 patients with respiratory failure should follow the existing data-driven ARDS protocols and should be adapted to account for local resources and outcomes. Patient ventilator asynchrony is a common problem encountered during lung protective ventilation. The most frequent causes are inadequate sedation, inadequate minute ventilation, inappropriate inspiratory flow settings or inspiratory time settings, and the need to maintain a lower tidal volume than desired by the patient. Common causes of patient-initiated high tidal volume demand are fever, respiratory and metabolic acidosis, hypoxemia, lung deflationary reflexes, pain, anxiety, or almost any discomfort or prominent bodily sensation. Therefore, the first step in treating asynchrony is to evaluate and treat patients for readily correctable problems, particularly insufficient control of pain, anxiety, or other sources of discomfort. Recommendations for the optimal use of neuromuscular blockade in ARDS vary, but can be beneficial, especially when an adequately sedated patient remains dysynchronous. Of note, paralysis is not required for proning, although it can be helpful in some patients. If a patient is otherwise optimized and remains hypoxemic, we may try a recruitment maneuver, although this may have potential risk, specifically due to hypotension and barotrauma or volutrauma. Many of these patients, especially early in their course, may have relatively higher compliance than what might be expected with other ARDS patients. They can thereby be recruited with improvements in their oxygenation.
We provide gentle, sustained increases in pressure to reopen the atelectatic areas and increase the surface area for a gas exchange. We recommend a titrated PEEP strategy using gentle PEEP increases rather than a more abrupt increase in the PEEPs. For more details, please refer to the written materials regarding recruitment maneuvers and a best PEEP trial.
There are a couple of additional adjuncts to ARDS management that are worth specifically noting in the context of COVID-19. A dry lung strategy may be appropriate. We know from other patients with ARDS and critical illness that the use of diuretics and fluid restriction reduces lung edema and improves oxygenation. The largest study of fluid therapy in ARDS, the FACT trial, found that even in the absence of obvious fluid overload, restricting fluid intake by using minimal intravenous fluid rates, along with judicious small fluid boluses and diuretics to maintain a mean arterial pressure above 60, kept most patients fluid neutral. This strategy can improve oxygenation, lung mechanics, lower PEEP requirements, and reduce the duration of mechanical ventilation without increasing the incidence of shock or the need for renal replacement therapy. While the same approach can be pursued in COVID-19 patients, it is worth noting high rates of renal failure are reported in these patients. Diuresis should therefore be done with close attention to the intravascular volume status and the patient's renal function. COVID-19 ARDS patients do seem to respond well to proning.
Due in part to the significant de-recruitment component, proning a patient when they have a P to F ratio of less than 150 seems to be an appropriate approach. These patients can do well with proning. I would note, however, that proning is not something that should be undertaken by a couple of individuals at a time. It needs to be a system-based approach. You have to have buy-in from nurses, your respiratory therapist, your technicians. Everyone has to be participating to do this safely.
Inhaled pulmonary vasodilators may have a role in patients with COVID-19. I would note, however, that some centers with access to epoprostenol and inhaled nitric oxide do not recommend using epoprostenol due to the potential need for more frequent circuit disconnects to change filters that become clogged by the epoprostenol. While some centers are prioritizing the use of nitric oxide if the patient requires any sort of inhaled pulmonary vasodilator, other centers, especially those with adequate PPE, are using epoprostenol safely.
I would emphasize again that pulmonary vasodilators have never been shown to improve outcomes of mortality or ventilator days or other clinical outcomes in patients with ARDS. They do improve oxygenation, and therefore, as part of a multimodal strategy, especially if they're being used as a bridge to other therapies, they can have an important role. Additional therapies include antibiotics. We know that bacterial co-infections are very common in patients with viral pneumonias. Decisions about antibiotics for possible bacterial superinfection or ventilator-associated pneumonia must be tailored to the clinical scenario. The use of steroids is an evolving area of clinical practice, and we recommend closely evaluating the current data, which at the time of this video were mixed, although many centers are routinely using steroids for COVID-19 patients with respiratory failure based on the recent trial of dexamethasone in COVID-19 in patients with hypoxemic respiratory failure. The role of other medical therapies for COVID-19 patients is still being determined. There are several adjunct therapies that, if available in your facility, may have some benefit for COVID-19 patients. Our recommendation would be to talk with your local infectious disease experts about the appropriate use of these medications. Many other things that we do in the intensive care unit are also not appropriate for patients with COVID-19. Routine chest x-rays, the daily chest x-ray, really has no role here. You're exposing potential healthcare workers to the patient for really no benefit. We follow the patients clinically, not with their chest x-ray. Similarly, bronchoscopy probably has very little role. There are patients who have a significant secretion burden, but most of those can be managed by suction rather than bronchoscopy. I would note that if you're going to suction the patient, it should be done as an inline suction, and everyone in the room should be wearing N95 masks and aware that this is happening to prevent aerosolization and possible contamination. It is also worth noting that patients with COVID-19 are often reported to be difficult to wean from the ventilator. In the largest study to date, COVID-19 survivors requiring invasive mechanical ventilation had an average duration of approximately 14 days. What we find is that when we change patients over to pressure support, even if they had been looking well on assist control mode, they often de-recruit and deteriorate precipitously, mandating that they go back on volume control. In these circumstances, it is important to evaluate potential sources of acute hypoxemia and distress. For example, during SBT weaning, the sudden withdrawal of mandatory breaths, along with the drop in the ventilator driving pressure by using a pressure support level of 5 to 7 centimeters of water, can result in an abrupt drop in tidal volume that can lead to de-recruitment. A sudden increase in the patient's work of breathing and associated anxiety can also contribute to this phenomenon. As this pandemic continues, we will learn more about how to best take care of these patients. Right now, there are many controversies and many questions unanswered.